So before I start, I thank AIOS for giving me this opportunity to present. So I would be talking about tough situations in Smile and how we aced them. So life is like a mirror, smile, and it smiles back at you. So now we know a lot of things about this refractive lenticule extraction Smile. This is the latest technology. It is purely femtosecond laser based. There is no flap created. A very small corneal incision of 2 to 6 mm is required. A better corneal integrity because of no flap and almost very minimal to no dry eyes. So just before starting with the complications, just brush up with the steps of Smile. So first, topical anesthesia, sterilization and draping. Then the eye centration and fixation with the blinking green light of Visumax 500, what we have in our center. Then docking with a curved surface suction fixation cone. Then the femtosecond laser firing starts. As sir also said, first it is the lenticule deep cut. It is centripetal from out to in. Then the lenticule side cut. Then the cap cut, that is superficial, that is centrifugal from in to out. And finally the entry pocket, that is superior or superiotemporal based on the ease of the surgeon. Then the suction is released and the eye is undocked. Then the manual dissection of the lenticule is done with the Duckworth and Kent Smile double-ended dissector with a spoon chip. First the cap dissection is done and then the lenticule. Finally lenticule extraction with Smile lenticule removal forceps. So now let's see a small video. So the lenticule cut, side cut, now the cap cut and the entry wound. Now first the cap dissection is opened up, then the lenticule is opened up. Now the cap dissection is done with the spoon tipped end of the Duckworth Kent. Now the lenticule dissection just beneath.
Did you use 800? It's so fast.
No, 500. The video is fast forwarded to.
I thought it's faster than 800.
No.
It was about 1000.
Just to fit into the 7 minutes time. So, yeah. Okay. So now, what intraoperative complications we come through? So literature says some of these complications like suction loss, altered or incomplete opaque bubble formation, dry spots, decentration of ablation, incision tear, complications during lenticule dissection, and an incomplete lenticule extraction. So let's see one by one. So this is the most common complication almost all of us face. This is suction loss during docking. Just I was discussing due to the 28-second time of the laser firing in Visumax 500. So literature says about 4% of cases undergo suction loss and majority have suction loss during creation of the anterior lenticular surface. So what kind of patients we face suction loss? The most common of it is Bell's phenomena, a sudden upgaze of eye turn, then anxiety, pain, tears in the conjunctival sac, pseudosuction, improper docking, low docking pressure system, and a new surgeon who is doing Smile for the first or second time. So how to ace it? So as per the literature, if suction loss occurs before laser initiation or during creation of less than 10% of the posterior lenticule surface, we continue the procedure with the same parameters. If the suction loss occurs after creation of more than 10% of the posterior lenticule surface, the procedure is converted into a femtosecond or a flap procedure. Now if it occurs during creation of the lenticular side cut, the same procedure is done after decreasing the lenticule diameter by 0.4 mm. And if it is after the creation of anterior cap surface or incision, it is done with the same parameters. And if after the lenticule side cut, retreatment in the same settings could result in hyperopic correction. So that time the procedure is aborted and a reprocedure is planned later. So I'll show you one case with suction loss, again a fast forward video. So in this case, the suction loss was just after the cap cut. Now there is a suction loss. Now redocking is done and the entry wound is prepared and rest of the procedure is carried out normally and whole lenticule was extracted out. So when the patient presented next day post-op, the visual acuity was 6/9 partial in that eye, which gradually improved to 6/6 and 6 in the coming month. So two more similar cases. The first case, suction loss was during the posterior lenticule cut. We can see around 50% of the procedure was completed. The procedure was aborted and planned for femtolasic with a decreased flap thickness of 90 micron. In the second case, the suction loss was there as soon as the laser firing started. So the patient was counseled, calmed down, redocking was done, and the procedure was completed with the same parameters. Now the second complication which we faced was dry spots during laser firing. So occurrence of multiple black islands of incomplete photo disruption after femtosecond laser. So when the docking is placed, generally the interface should be clean and devoid of any debris, water, meibomian or conjunctival secretion. Otherwise, the laser firing is incomplete and the dry spot create, and dissection of lenticule is difficult due to microadhesions between the lenticule and the corneal stroma. So this is one video. See, there was a dry spot. The laser did not penetrate. And there was a difficult dissection at that point of time in that particular area. The dissection had to be forcefully done, taking care that cap perforation does not occur or the incomplete lenticule is not taken out. But at the end of the surgery, complete lenticule was taken out. The lenticule is taken out, and next day the visual acuity is 6/9 and the ASOCT. Now another complication which we faced is incision tear. See, this is the eye where the incision tear took place. It is generally encountered during early learning curve due to increased manipulation during dissection, smaller incision site, strong Bell's phenomena, and sudden head movement of the patient while the instrument is still in the interface. So we can treat it with bandage contact lens and copious amount of lubricants. And if there are irregular tears with excessive dissection, it can disrupt the epithelial cells at the site of the tear and may be a source of epithelial ingrowth. So this is one more complication.
Can you please sum up?
Yeah. So there was corneal scar with vascularization at the standard incision site. So the incision site was shifted from 90 degree to 150 degree. And all the maneuvering was done through the new incision site. So these are some other complications, which I'll just go fast. So the take-home messages. SMILE requires greater technical skill and has a steep learning curve compared to PRK and LASIK. An in-depth knowledge of various complications, prevention, and management of these complications are required for good visual outcomes. Thank you.
Thank you very much.
I think Dr. Payal is one of the only SMILE surgeons who has also undergone SMILE herself. So one line about how the patient feels during those 28 seconds.
Yeah, actually I was very nervous. I was tensed. And because I have seen suction losses before, means I underwent SMILE after observing this procedure for 28 days. I was very nervous that suction loss or something shouldn't happen so that my vision gets lost.
It will not lose. Nothing will happen. Even suction loss can be managed very well.
Even I got 6/9 vision on day 1, and after 1 month I got 6/6 vision.
Wonderful.
Good.
So
Wonderful.